Hi everyone, my name's Hugh Simpson. I'm one of the neurology fellows here in the clinic, and I've recorded this talk for you on the 23rd of September of 2020. So just a little bit about me first. So I'm interested in headache, but I'm also interested in movement disorders, which for us neurologists is essentially Parkinson's disease, epilepsy, and then neuromodulation for a lot of those treatments. If you have any questions about the talk, please feel free to contact me via the organisers. Normally I would say that if you see me around, then please feel free to say hello. Less likely in these times, I guess. And just as a brief warning, you might not recognise me from my relatively clean-cut times last year to post-COVID, where I've had limited access to hairdressers like the rest of us. So letting things go a little bit there. So I'd like to start today with a quote, if I could. So this is from around 1200 BC. "Headache roameth over the desert, blowing like the wind, flashing like lightning. It is loosed above and below. It cutteth off him who feareth not his God like a reed. This man it has struck, and like one with heart disease he staggereth. Like one bereft of reason he is broken." So I think we can all kind of sympathise with this particular Mesopotamian and acknowledge that headache is an ancient problem and affects people across the world and through time as well. Now, in this particular instance, the Mesopotamians attributed headache to the evil spirit Hugh that would cause headaches and attack its victims and lead to these terrible symptoms. Hopefully we've learned a little bit more about headache since attributing things to evil spirits, and I'm hoping to convey a little bit of that to you today. Before we start, I want to just have some quick definitions, and I know that a lot of the audience are not medical professionals, so I'll try and use as little jargon as possible. But it's useful to know that we sort of divide things into primary and secondary headache disorders. A secondary headache disorder, to start second first, is something that is caused by another problem, a separate problem if you like. Probably the most common example is having a cold or a flu and feeling a bit miserable and having a headache with that. That would be a secondary headache cause. Neck problems, so problems from the neck which cause headaches, and then some of the more serious stuff like brain tumours. So that's some other process that's causing a headache. And then there are a group of headache disorders that we call primary headache disorders that happen kind of for their own, in and of themselves, if you like. No definite reason to have them, although they can have triggers. And so of these primary headache disorders, by far the most common is migraine, and then tension type, as well as tension type headaches, and then cluster headache is relatively rare. So I've divided this talk into two main parts. So the first is talking about headache and migraine. What are they and why do they matter? And then new developments in migraine. And I'm going to use this new developments to try and explore two of the main theories about what goes wrong in migraine, essentially. Now, I've mentioned migraine a couple of times, and you may think, well, this guy is supposed to be talking about headache. And if you finish this talk and you think, well, all he really did was talk about migraine, then I wouldn't be too worried by that, because certainly for us neurologists and for a lot of the burden of disability throughout the world, the most problematic thing by far in headache is actually migraine, which I'll unpack for you now. Just starting with headache in general though, I don't need to know who's watching this talk to know that 1 in every 2 of you will have at least one headache this year. For people who visit their primary care physicians for their headache, 90% of that will be due to headache disorders. So headaches are extremely common, and of the headaches, then these primary headache disorders are things like migraine and tension headaches are the overwhelming, more likely causes, if you like. Similarly, for visits to the emergency room, so there's about 2% it comes out to of emergency room visits are due to headache, which is huge. This equates to 1 person every 10 seconds visiting an emergency department throughout the United States for their headache. So I've been talking for just under 5 minutes now, and so that means that in the time that I've been talking, 30 people will have lined up outside an emergency department somewhere in the US complaining of headache. By the time I'm finished talking to you now, almost 250 people will have queued up outside emergency departments in the US. So this is a huge problem. Similar to the primary care numbers, 2/3 of headaches of people with headache who present to the emergency room will eventually be found to have a primary headache disorder like migraine or tension type headache, and 1/3 will be caused by something else like neck pain. So hopefully now I've at least partially convinced you that a huge part of the problem and burden from headache is actually migraine, and so I'll be talking largely about migraine for the rest of this talk. So how bad is it? It is the third most prevalent condition in the world. It is incredibly common. 1 billion people worldwide suffer from migraine, which translates to 1 in 4 households have someone who suffers from migraine. The migraines disproportionately affect women, as you can see here in this infographic, which I have sourced from the American Migraine Foundation, so up to 20% of women, and a little bit less common in men. Something that's perhaps not as well appreciated is that migraine commonly affects children as well. So up to 1 in 11 children will have a migraine at some point. And these numbers range from about 10% for school-age children up to about 1/4 of adolescents. I'm sad to say that in children as young as 18 months, headache has been diagnosed, or migraine, has been diagnosed. So it's a little sad, but almost as soon as we can talk, we can describe the symptoms of migraine, or at least tell people that that's the symptoms we're suffering from. And as you might expect, this all translates to a huge financial and economic burden. The numbers I quoted in the previous slide were for headaches in terms of emergency department visits. For migraine alone, 1.2 million emergency department visits per year are for acute migraine attacks. 4 million people in the US have chronic migraine, which we define as more than 1 in every 2 days or 15 days per month. And as I don't need to tell any of you who suffer from migraine, 90% of people are unable to work or do their normal activities during migraine attacks. Now, going back to the perhaps less appreciated children who suffer from migraine, this includes school-age kids as well. And so this really significantly interferes with schooling for many children. And we know that children who suffer from migraine are twice as likely to be absent from school. With respect to adults and migraine, the loss of productivity estimated from migraine in the US is $36 billion, that's $1 billion every year. And every year about 157 million workdays are lost to migraine every year. In addition to this, there are some indirect costs of migraine as well. So we know that people complaining of severe headaches are going to get brain scans, and oftentimes that's appropriate, but sometimes it may not be as appropriate, and this adds up to a cost of about $60 billion worth of brain scans being done in the US every year for migraine and headache. Sorry, $40 billion. And so we know there's a great need. 39 million people in the US have migraine at the moment. And what about the resources available to those people? So despite the huge burden of disease for migraine, there are only 500 certified headache specialists at last count in the US. If you were to do the math on this, then that works out as about 80,000 patients for every migraine specialist, which is obviously grossly inadequate. In terms of funding, the picture is not much better. So in 2007, the National Institute of Health, a major funding body here in the US, estimated that when you take into account how many people have migraine, that this works out to about 50 cents per person. And 50 cents does not go very far, as you can imagine. So it's not surprising then that people with migraine are underserved by medical services. So we know that half of people with migraine are never diagnosed, and most don't even seek medical care for their pain. And this may be partly to do with resources, but I think it's also partly due to what I think of as a normalization of headaches. So I can't count the number of times when I've assessed somebody in the hospital or in clinic, and when I ask them if they have migraine, they say, "Oh no, I just get normal headaches." And it takes a moment or two for me to remind people that there are no normal headaches. Pain is not a normal human condition. There are more common headaches, and there are headaches caused by understandable everyday things like colds and flu, but there are no normal headaches. And so with this in mind, and this is sort of one of my take-home messages as well, it's more understandable to see why only 4% of people with 4% of people with migraine see headache or pain specialists in the end. And this is despite the fact that over a quarter of people with migraine are eligible for some sort of preventive medication that could actually help them. And only about half of that, about 12%, receive preventive medication. So half of people are never diagnosed, and only half of those who are diagnosed receive appropriate treatment. So what are we talking about? I probably don't need to convince most of you or explain to most of you what a migraine is, but I've used here the International Classification of Headache Disorders version 3, ICHDA3, which is the current diagnostic standard for migraines. And you don't have to think about read this in too much detail, except to know that attacks tend to be prolonged, so hours to days, and they have to have a number of these qualities here. So one-sided headaches, pulsing or throbbing quality, moderate to severe pain intensity, worsened by physical activity or cause you to avoid doing normal physical activity, as well as one of either nausea or vomiting, and what we call photophobia or phonophobia. And those just mean sensitivity to the light or sound. Now, I think looking at this, you can understand why maybe a lot of people don't appreciate the severity of their headaches, or the fact that they may have migraine and not know it. Because I think previously people used to imagine, and a lot of people still do, that migraine headaches are those terrible, thumping, severe, earth-shattering headaches that leave you curled up in a ball, perhaps lying in your room in the dark and vomiting and unable to come out for a day or two. And certainly those are migraines, and we have a lot of people who suffer from migraines like that, but a lot of more mild syndromes actually fit into this category as well. So just as an example, let's say you're going about your day, it's about lunchtime as it is here when this is being recorded, and you notice just a little bit of a headache. Maybe it's a little bit throbbing on one side of your head. So immediately you've kind of ticked 2 out of these 4 boxes. It doesn't really stop you what you're doing. You may or may not take some acetaminophen or Tylenol to help with it, and you just go about your day. A couple of hours later, you notice it's still there, and then when you're, let's say, walking home at 5 or 6 p.m., you notice that the light's bothering a little bit more than normal, and then you get home and you maybe take some Advil and it goes away, or it goes away by itself after several hours. So you may not think of this as a migraine because it's very mild, and many of you listening to this will be realizing for the first time that you do have migraines, because you, in fact, if you had 5 of those attacks, days like that, then you would meet the definition for migraine without aura. So that's the commonest migraine. 75% of people have migraine without what we call an aura, which I'll talk about now. So migraine with aura is is called the classical migraine. It's probably the most recognized one. In addition, with that feeling of being lying in bed and being curled up in a ball vomiting, people will tend to, the most commonly appreciated symptom is this visual aura, where you get some flashing lights and sometimes a blind spot as well, which I'll go into in a moment. Now, as well as the visual symptoms, which is the first symptom I've listed here, you can also get sensory symptoms like numbness or tingling, difficulties with speech and language, so having some problems finding words, as well as vertigo or difficulty with your balance. Now, I don't want you to read too much into the rest of this list, but characteristically, auras last in the order of about 20 to 30 minutes, and I've given you a range there, and they spread. So let's say you have some tingling, it'll start off in your face, it'll spread to your shoulder and your upper arm over about 5 to 10 minutes, maybe down to your hand after about 20 minutes, and then it'll stop. So that slow spreading neurological symptom is a typical pattern for an aura. So the visual aura that I mentioned, you can find many depictions of this. This is one of the better ones that I just found on the internet, and this is what's called a scintillating scotoma. So there are various ways to describe it. Some people call these fortification spectrums because these jagged lines look like the walls of a fort. Scintillating because it's sort of got a shimmering or multicolour nature, and then a scotoma is just sort of our speak for a spot where you can't see. Now this can be bright, as is depicted here, or it can be perceived as being dark, so an absence of anything. I've got a video which this should link to, and so this is just a little something on migraine with aura from Mayo Clinic, and I I would encourage you to use some of these resources if you're interested, because
A migraine headache is caused by changes in your nervous system. Migraines can progress through 4 stages.
Because there's some useful information
aura,
in here.
Attack, and
I'll talk
post-migraine.
more about
Not everyone experiences all the stages.
this later on, but this is a good description of an aura. So you have a problem that goes on in the brain here, bit it up the back.
The best known visual aura is called a fortification spectrum because its pattern resembles
And then here it
the
talks
walls of a
about
nuclear fort.
this
It can
fortification
start as a
spectrum.
small hole of
aura.
light, sometimes bright geometrical line.
So you see this person's walking around, there's an area in their vision that seems to be missing. There's this shimmering quality to the corner, and it's slowly spreading. So this is that typical spreading over a number of minutes neurological symptom, and in this case a visual symptom. It can be flashing lights like they're trying to depict here, and eventually it can even take out almost half of your vision, something that we call a scotoma. Typically, as I think the video is about to say, this lasts about between 5 and 60 minutes. So there are some good videos on that on the Mayo Clinic website. It's worth checking out if you're interested. I'm interested in migraine. A lot of neurologists are interested in migraine, and a lot of neurologists actually have migraine. So I'm from Melbourne in Australia, and at a recent conference that we had a few years ago, a survey was done to see how many neurologists have migraine, and 2/3 of neurologists reported that they had migraine, which is higher than the general population. Almost as many trainees in neurology, and only 50% of the rest of the conference reported a personal history of migraine. So this led the authors to ask a question. So, is this just the fact that neurologists kind of diagnose themselves better than average folk, and is migraine actually this common and it's only neurologists who can self-diagnose? Or has this influenced people's career choices? Do people with migraine choose neurology as a career in the same way as a lot of people who have a certain condition will choose to study that in their career? Probably a little bit of both, realistically. So at the beginning I started with a quote from the Mesopotamians talking about the evil spirit of headache called Hugh, which attacked people. And so we know that migraine, or headache at least, is as old as antiquity. And there are some scrolls from 3,000 years ago here, and then writings from Hippocrates in 400 BC, of course, who was a prolific medical writer. And then Aristeas created one of the first headache classifications. And perhaps it's understandable if you thought this was an evil spirit inside you. We can understand why there is some very strange ancient remedies, one of them which was trephination. So people would actually try and put a hole in somebody's skull in order to let out the evil spirits or bleed out the humours. And there were many more. I want to just read one more quote, which when I read it was really struck me as saying, reminded me of the modern day experience of migraine. So this is from someone called Phoenix. Phoenix's complaint was of such a nature that flashes like lightning seemed to dart from his eye, and generally his right eye. Sounds a lot like a visual aura, right? Not long after, a violent pain seized his right temporal and then his whole head and neck. So that's severe, one-sided. He's meeting the definition so far. The back part of his head at the vertebrae swelled, and the tendons were upon the stretch and hard. Probably some poetic license here, but I think they're trying to say that he had severe pain. Now if he attempted to move his head or to open his teeth, a pain seized him from the violence of the stretch. So here we see that movement caused worsening, another headache, a migraine criteria. And then vomitings, whenever they happened, removed the pains now mentioned or made them easier, so there was vomiting as well. So I would argue that 3,000 years ago, this man met a very modern criteria for migraine with aura. And again, there's mention of the treatments. Bleeding was apparently useful, and then there were various ways of trying to draw away the humours. So I hope that in the 3,000 years since, you would hope that we've been able to develop some better medications, and I'll go into that in a moment. But before I do, I want to talk more about the experience of a migraine attack itself. So migraine has a number of phases, some of which are very well understood and some of which less so. The headache phase, the most well known, I suppose, or the most obvious part of headache, is in a way the least interesting. Here we see that it lasts 4 to 72 hours and has all manner of awful symptoms associated with it. So this is reasonably well appreciated, as well as what we call the postdrome. So we know that after the headache of migraine leaves, people don't immediately get back to what they're doing. They tend to like to sleep their headache off. They often have trouble concentrating for a while afterwards, and maybe even feel a little bit of depression as well. So these two phases, the headache, if you like, and then the postdrome, are quite well known. The aura we've talked about, also very well recognized in certain circumstances. And just one thing I wanted to add here, that initially and classically migraine aura is supposed to last about 20 minutes or so and then disappear before the headache. But it can last longer, and this is a cause for confusion in medical circles as well as amongst everyday folk. And we know that aura can come on at the same time as a headache, or it can certainly persist while the headache is happening. And so you have circumstances where people have numbness, tingling, visual problems or weakness, as well as a headache that persists for hours. And one common issue there is that this gets mistaken for a stroke. And one of the common requests that I've had and all neurologists have is to try and differentiate migraine from something more serious like a stroke or even a seizure sometimes. So this prolonged aspect to aura is very important to appreciate. Probably my favorite thing I've learned about migraine, though, is the prodrome, also known as these premonitory symptoms. So it's been only recently appreciated that in the hours to days, and yes, days before a migraine occurs, there are changes in the brain and body's physiology that are all part of a migraine response. So the most common ones are things like irritability and depression, and then there are some strange, very physiologic ones like yawning or an increased need to urinate. And in fact, I read a case report of somebody who would suddenly begin yawning several times per minute out of nowhere, and this was almost as reliable for this patient as an aura was, and she could take medication to help prevent the headache from happening. Probably the most fun one, though, is food cravings. So, and this helps explain one of the many misconceptions there are about migraine. And in this case, what has probably happened is people misattributing migraine to as being caused by chocolate, for example. So people commonly think that things like chocolate or other foods can cause headache and migraine, and while some foods certainly can, the chocolate may be more innocent than we thought. What actually happens is that we have this migraine prodrome, so what the migraine is beginning to work in some sort of a way, and it manifests as a craving for food, and particularly sweet foods. So people are already in a prodrome when they have a food craving and they have some chocolate. A couple of hours later they may have an aura and then a headache, and then they'll blame the migraine on the chocolate, when in fact the desire to eat the chocolate was already a sign that migraine had already started, if you like, or was always going to happen. So we know now that certain foods that we thought triggered migraines are actually just part of the whole migraine experience. And I like to think of this in terms of kind of like the weather, if you like, or a weather analogy. The prodrome is kind of like when you sense some sort of change in the weather hours to days before it happened. The wind's blowing in a different direction, the temperature drops, and yet nothing else seems to have obviously changed, but you know something's up. Then you have the aura, so this may be some flashes of lightning on the horizon, or you may have that kind of that smell of fresh rain may be on the air, and you know something's up. Something's about to happen, and happen imminently. And then of course you have the thunder and lightning of the headache and the severe pain itself, which then resolves and gives way to some feelings of relief, but also a period of 24 to 48 hours where things just feel different. So like the time after a storm. So I talked about triggers, in particular in relation to chocolate, and how that may be a little more innocent than was appreciated. So what does cause migraines? This is something of a thorny issue because, as I'll hopefully explain, some people can attribute their migraine to a certain cause when on review of the evidence it's actually not the case. And so I'm going to start with a list of more evidence-based causes for migraine triggers. So stress is one of the most common, menstruation for women, visual stimuli, as well as, ironically, given my weather analogy, weather changes. And there is some well-established reports of changes in the weather triggering migraines, and it can be a very local phenomenon for some people. Foods can cause headaches, but particularly additives like nitrates, MSG, and aspartame, as well as wine, unfortunately for many of us. Sleep disturbance is one of them, and I wanted to point out that we say sleep disturbance, not necessarily sleep deprivation, and I'll go into that more in the next slide. And unproven things like smoking, strong odors, chocolate, and other food additives. And I might add here that odors is one of these ones that gets reported, so I'll go over to this next page. So this is a list of triggers from a survey of people. So this is what people think has caused their headaches. And you see odors here and smoke, for example, and then neck pain. But as I've hopefully explained, these may actually be part of the migraine prodrome. So when somebody says a strong odor has caused them to have a migraine, that may actually be reflective of some sensitivity to smell that can occur before a migraine. So it's not the odor itself that was causing the migraine. It's just a marker that the migraine was going to happen or is about to happen anyway. So some things that overlap from the evidence-based list are emotional stress is very reliably implicated, hormonal changes in women, not eating or missing meals, we're back to the weather again, and then sleep disturbances. So I wanted to make a point here about sleep and stress, and we know that sleep disturbances, as well as things like sleeping late, can cause headache. And what we've essentially found is that not only can sleep deprivation lead to migraines, but also excessive sleep, and particularly changes to sleep. Similar with stress. High levels of stress or changes in your stress level can cause headache and migraine, as well as when a stress is relieved. So I'll give you the example of what I've seen not infrequently in some of my colleagues in medicine, is when they're working, it's what I think of as sort of a Saturday morning migraine. So they're working very hard Monday to Friday, sleep deprived, sleep 5 or 6 hours a night, very stressed, and then finally on Friday night and Saturday morning they can sleep in, their stress level drops right down, they become relaxed, they sleep for 9 hours instead. And suddenly on Saturday during the day they get a terrible migraine and knocked out for the rest of the day. And this is a phenomenon that we see because of the changes in a sleeping pattern and the changes in a stress. So not only can sleep deprivation cause stress, but a sudden change from not sleeping much to sleeping excessively can do it, and similar for stress. So unfortunately, in a way, you're kind of darned if you do and darned if you don't. But migraineurs tend to have to be creatures of habit as a rule. So I've talked about some triggers here, but what actually causes migraine? Well, the short answer is we don't know, and so we revert to the nature and nurture story. We certainly know that genetics are very important. 90% of people with migraine have a family history, so when in doubt, blame your parents. No single gene is responsible for migraine apart from some unusual conditions like familial hemiplegic migraine. And so the way to think of it is that your genetics give you sort of a susceptibility or a susceptible background, and then life unfortunately gives you the rest in terms of triggers like stress and good things like alcohol and wine, etc. Just briefly though, there are some other associations that I think are worth pointing out. We know that people with motion sensitivity or motion sickness are more prone to migraine and vice versa, and that there is an association with age. Now, migraine is a disease of all ages, as I'm going to show on this next slide, but it's more common in midlife. So here we see a graph where again the disproportionate effect on women is shown. So women here are shown in the red bars, different ages here across the horizontal axis. So at all ages, women suffer more than men, and then we see that both for men and women though, that the peak ages are in the 30s and 40s really. And this is partly why migraines are such a socioeconomic problem, in that these, as you'll notice, are conveniently in the middle of the most productive years. So whether it be schooling or work life, this migraine takes people out in the most productive times. So I'm going to attempt to explain a little bit of the science behind migraine. I'm going to try and use as familiar terminology as I can and not dwell too much. But if some of this goes over your head, that's okay. So when we talk about pathophysiology, pathos is Greek for suffering, physiology is the functioning of the body. So It's the bodily function during disease, if you like. Now, there are a number of different systems or things that have been identified in the genesis of migraines. One is this idea of cortical spreading depression, which I'll talk about more. It's about some spreading wave of brain dysfunction. Then there are these long words which essentially say that the interaction between the nerves of the face and head and neck are all connected, and they're connected to the blood vessel systems, and changes in this affect or are caught up in migraine. Serotonin is one of the things I'm not going to talk about too much, because essentially we know it's involved because serotonin-based medicines work, but the exact mechanisms apart from that are less well understood. Sensitization is important, but some of the mechanisms behind it aren't as well understood either. Sensitization here just refers to the idea that you're overly sensitized to normal phenomenon, so it's often referred to as central sensitization. Probably the most obvious example to understand this, though, is light sensitivity or photophobia. So you walk outside, normal experience of being in the sunshine is uncomfortable or painful when you have photophobia. So this abnormal sensitization is a very important part of migraine. And then finally, the most uncomfortable part of migraine, the actual pain of the headache, has a very complex system of chemicals and molecules that involve, but for our talk, the most relevant is going to be CGRP. So I'm going to comment on these three boxed systems, and I'm going to leave serotonin and sensitization for the moment. So, cortical spreading depression. What's this all about then? So this is something that people have noticed on brain imaging studies and confirm some abnormalities. So even though you may go to hospital and have an MRI scan of your brain, there's nothing wrong. There's nothing wrong with the structure of the brain. When we do some imaging of the function, so how much glucose the brain uses, how much oxygen that you use via the blood supply, we see a different story emerging. So I've got a picture of the brain here. If you're not used to looking at the enchanted walnut, this is the front of the brain here. This is the back of the brain, the cerebellum. We've got the spinal cord. This area in blue here, hopefully you can see the cursor, is the occipital lobe. So that's the part of the brain where visual function resides. And here the blue area is colored to say that this is not functioning normally. So dysfunctional, low function. The function is depressed. And then on the outside of this, on the border, we have this area of increased function, so hyperfunction or excessive function. And this slowly spreads across the brain, leaving a trail of, not quite destruction, but a trail of low function to the point where once the wave spreads to a certain point, it just leaves the brain that is depressed for minutes to hours. If this sounds familiar to you from what we talked about with the aura, then it very much is. It's a direct correlate, a direct result of that. So the occipital lobe is the visual part of the brain, and we see the visual experience of that is that the scintillating scotoma, the sort of brightly colored shimmering outside, corresponds to the wave of increased activity, whereas the blind spot, the dark or bright spot within, corresponds to the area of low function, and this spreads across the brain in exactly the same way as it spreads across our vision. So we know that auras at the beginning of a migraine are caused by this or by this cortical spreading depression phenomenon. So what happens next? Essentially there is a complex series of molecules and messages in the body which you don't have to get too tied up with. So there is what's called the trigeminocervical complex and the trigeminovascular complex. Probably the easiest way to think of this is there's the axis of head and neck pain, or face and neck pain, and they're linked together. And then there is a system of nerves and blood vessels which is linked together as well. And I'll broadly illustrate that here. So these things are nerves, the purple and the pink colors, and so these are the nerves of the face, and these blue ones here are the nerves of the neck, and they go together and synapse in a part of the brain called the brainstem, and they have in some cases, connected circuitry. So that's how they're kind of tied together, if you like. You may not necessarily think of pain and other sensations in the face being tied to the neck, but this is what the neuroanatomy tells us. In turn, these neurons, that mediate sensation in the face and neck, are tied to the blood vessels, and then this system then is all tied back into the cortex, where we see this wave of spreading depression. So why this is important is because, as you may or may not know, that the brain itself, the brain tissue, is incapable of feeling pain. It's insensate, as we say. There are no nerve fiber endings in the brain. So even though your head may ache, your brain does not ache as such. What we do experience pain through are through the sensory nerves of the face and neck, and we also experience pain when the blood vessels can expand or contract. And so that's why these systems are all connected together in migraine, and that's why they're important. So let's talk about treatment. I want to talk about some of the more exciting treatments in migraine that have been developed in the last few years. But before that, I've got to talk about the bad old days of what I call non-targeted therapies. So in the early days, essentially we had things which weren't specifically targeted to migraine. I've classified, as we often do, in terms of relieving agents or abortive agents, and then preventive or prophylactic agents. And so these were all non-targeted. So for relief, you can take high-dose aspirin or anti-inflammatory drugs like ibuprofen and Advil, and these have evidence, they work, but they have side effects like on stomach, for example, and blood thinning that may not be desired. And then in terms of prevention, things were really let down. So there was no tailored drug therapy to prevent migraines. Instead, what people ended up doing was trying medicines that were used for other purposes, so for blood pressure, for seizures, for depression, and even just vitamins. People would try anything to see if this would help with migraine. And there were a few that seemed to help. They helped a little bit in terms of reducing the frequency of migraines and the severity of migraine attacks. As a rule, though, these weren't that effective and they had a lot of side effects. There was weight gain, poor concentration, low blood pressure, low mood, and all sorts of things. So they weren't that effective, and they had a lot of side effects. So then came some of the scientific breakthroughs. So the main theme, and you'll see this theme throughout the next few slides, is calcitonin gene-related peptide, or CGRP. You can immediately forget that name, and if you want to remember it somehow, you can say, can get really painful. So molecule that causes pain. We know that it's involved in migraine and headache because when we injected it in some studies, and I say we, not me, into some unfortunate people, it caused migraine and headaches. And that's when we injected it into somebody. It is a naturally occurring substance as well, and when measured in its naturally occurring state, we see that it goes up with migraine. So here in this graph on the right, you see that in the blue bars are people who are not currently having a migraine attack. The red bars are they're currently having a migraine attack. And you can see that this concentration of this molecule goes up in the attack, whether they're having an aura or not. And then we noticed that when I talked about we know serotonin is involved, one of the reasons we know serotonin is involved in this is because a serotonin modifying medication, sumatriptan, when given, stops this increase in this pain molecule. So sumatriptan was a new discovery in the 80s and 90s, and we know that it prevented some of the pain from migraine. So for the first time, and this was in the 90s, we had a targeted therapy for migraine. They're referred to as the triptans. The first drug was sumatriptan, and then they were followed by many other triptans, including rizatriptan, elatriptan, and so on. Now these were a revelation. So many neurologists consider these as some of the most important drugs of that decade, and the American Headache Society, in fact, said it was the most important breakthrough in headache in 50 years back in 2008. So this was a big deal and provided a lot of people with significant relief from their headaches. There was essentially no movement on targeted medications, same as it was before. I've put Botox in here, or botulinum toxin, because at a similar time we realized that injections of botulinum toxin could actually help prevent migraines when given for months to years. But it's not really a targeted therapy. So then we move on to CGRP. And from the same experiments that I showed you before, where it showed that CGRP was important in migraine, people try to develop therapies based on it. But it's only been in the last few years, in fact from 2018, where those drugs have come to market. They've actually been able to be developed in forms that can treat attacks acutely, so get rid of an attack when you have it, as well as for the prevention. And it's really this prevention where I think things have been revolutionized. And because from from the relief aspect, the triptans were already pretty reasonable in a targeted therapy, but from a prevention point of view, we really had nothing. And this is where I think it's an example of how scientific progress in neurology has really leapt forward and provided some amazing new treatments. And it's something that I'm really personally excited about. There's many advances in MS, in stroke, in other areas, but this has been a real huge leap forward in headache. And it's got a lot of neurologists, and particularly headache neurologists, very excited. It's been very slow progress though, so I don't want you to read all these boxes, but just to get a sense that CGRP was discovered back in 1982, and the drugs really only came to market in 2018, so almost 40 years. Now, why did it take so long? Well, there are a number of reasons, but probably the most recent one was that after some initial clinical trials of drugs based on this molecule showed benefit, there was a problem with some of them causing some liver damage. And so essentially that really set things back for a number of years, and it's taken until now to develop versions of this therapy which did not have that same problem, and the current ones do not, of course. So I said there were two main groups. There are the relieving ones, and just in case you hear myself or others refer to these are kind of called the G-pants, because that's the last part of the name, Japant. So these are oral therapies, tablets, and they're given acutely. And then we have the injectable medications for prevention. So we call these monoclonal antibodies. They're essentially just blocking antibodies that we inject that can last for several weeks. Just to go on about the differences a little bit more, the small molecule therapies, as we call them, the G-pants, are given via the mouth. They only last from minutes to hours, and they're less specific, if you like. The antibodies are designed to very specifically target this CGRP molecule or receptor, but the problem is they take a while to act, up to a week to start to work. But they do last for weeks. So this is why they're better suited to prevention-based therapies. Now, how effective are they? So I'm going to skip over this left panel is the tablet-based relievers. They're essentially similar to the triptan, so in that way it's not as much of a leap forward. What's been the real breakthrough has been the injectable preventative medications here. So this is a graph which says how many people can achieve more than 50% reduction in their migraine days, so go from 20 days per month down to 10 days, and at least half of people can, and some people even had a more striking response where their migraine was essentially completely fixed. So again, just to highlight that this is a little table which lists the side effects. So in this column here we have side effects for the newer therapies, and here in the older therapies. So older therapies were less effective and had a lot of side effects, including weight gain, mood problems, drowsiness, difficulty thinking, whereas the new medications, although they do have some side effects and they are injection-based therapies, are far better tolerated. So what do we have now? We have these 4 medicines now, which are all FDA approved and available. They're injection-based therapies, and then these are the relievers. So as I mentioned, they're effective, they're safe and well tolerated, but they are, the main issue currently is expense. So to take one of these tablets to relieve a headache, for example, it'll cost you about $80 to $100 if you were paying full price, and then these preventative medications are up to $600, $500 or $600 a month. Now, we may hate migraines and you may not like having them, but is it really a $100 migraine? That's another question. Fortunately, a lot of the drug companies involved have got subsidization programs, so generally these are, at least at the moment, these are quite accessible. So that hopefully shouldn't be a barrier to you at the moment. One sort of last important type of headache that I wanted to touch on is a medication overuse headache. Now, this was a somewhat controversial entity in that a lot of people took convincing that this actually existed, and this is a headache that's essentially caused by medications you would normally use to treat headache, which is a little bit counterintuitive, but it's very important to know about. So this says that if you use anti-headache medications on even as few as 5 to 8 days per month, this can end up causing a chronic headache that you experience on more than 15 days per month. So the worst medicines for this are the ones that contain butalbital, as well as narcotics like codeine and oxycodone. Caffeine is problematic here, and so brand names like Fioricet and Excedrin are commonly implicated. The triptans can do it, but aren't too bad, and the lowest risk is with non-steroidal anti-inflammatories. So just to repeat, if you keep using these medicines and use them more than 5 to 8 times per month, this will actually perpetuate a headache cycle, if you like, and make your headaches worse than if you just didn't take the medications at all, which is a difficult concept. But it's very important because, you know, we've existed in the last several decades in a time when preventative medications were not effective, so unfortunately people had to keep using their relieving medications, which made things worse. So, you know, I'm hopeful that with better preventative medications there'll be less of this around. I'm just going to use the last few slides to talk about other therapies. These aren't necessarily new, but these are available, and just to make sure people know that they're out there. So nerve blocks, this is based on the idea that the nerves of the face and head and neck are all connected, and if we target one, we target them all. As I mentioned, there's Botox, botulinum toxin earlier, and then there's specific nerves, so the greater occipital nerves at the back of the head here. We know that if we do some injections of local anesthetic and steroid, it can actually help acutely treat cluster headache and migraine, as well as prevent them to a certain extent. Similarly, and this looks uncomfortable, this is a cross-section of somebody's nose. There is a collection of nerve fibers and cells called the sphenopalatine ganglion. It's located deep in the face, just at the inside part of the nose, and you can actually insert a little applicator, no needles, and just dab on some anesthetic, and that can provide acute relief of migraine as well. Again, important to know that that's out there. In the future, well, even currently, we have neuromodulation is also available. We know that similar to the idea of trying to block these nerves, we know that stimulation with electricity or magnetic fields can actually help with headaches as well. So there are nerve stimulators as well as TMS, transcranial magnetic stimulators. Probably the best known one is one called Cephaly. It's a little kind of, looks like an electronic tiara, and it delivers stimulation to the nerves around the forehead here, and this can actually treat a migraine when it's occurring and also prevent them from happening. Further on, there are more invasive options, so such as SPG stimulation with implanted stimulators, electronic stimulators, and then DBS, deep brain stimulation, is even being investigated for some types of headache, mainly cluster headache. This I thought I would mention because it's a little counterintuitive. We're going to do brain surgery on someone with a headache. How is that going to work? But it has shown some efficacy, although this is still very much a research-based thing. And I think it's kind of ironic and takes us back full circle to when the Mesopotamians were doing trepanation, so putting holes in people's heads to let evil spirits out. We are currently now doing neurosurgery in an attempt to help people with headache as well, which is a little ironic, but hopefully in a slightly more thoughtful way. Finally, it's important to know that lifestyle and behavioral therapies can be effective as well, and there's less interest in this from a pharmaceutical company point of view, and so of course there's less evidence. But certainly we counsel most people that keeping your sleep, exercise, hydration, and even caffeine intake as regular as possible is important. So minimize caffeine and then maximize sleep and hydration, but try and keep it regular as much as possible. We also know that cognitive behavioral therapy, which is essentially brain retraining, so retraining habits and thinking, can help and improve your response to medication. And we also know that biofeedback is useful as well, and some people have striking improvements. So biofeedback is when we give you information about what your body is doing. So things like skin conductance, temperature, heart rate, respiratory rate, and this helps you focus in and try and get a sensation of what's going on in your body. And just providing people with these feedback modalities can actually help and reduce headache and migraine. So that brings us to the end of my talk. I had a couple of take-home messages here. I wanted to reinforce that headache and migraine are incredibly common and debilitating, and generally underappreciated, underdiagnosed, and undertreated. In particular, there are no normal headaches. So if you have normal headaches and you have them on more than a few days per month, then think about seeing your primary care provider, or maybe even getting a referral to a neurologist. We know that migraines are strongly genetically determined and that they're to do with abnormal signaling between the nerves of the face, the neck, the blood vessels, as well as this abnormal spreading depression in the brain. We know that, and probably most importantly, I wanted to make you aware that there are these new migraine therapies available based on new research, which are really revolutionizing the way we think about migraine and treat it. They're super important because old treatments were hampered by a lack of efficacy and terrible side effects, which led to this medication overuse headache. And again, I would urge you, if you're using headache medication more than a few days in a month, then think about seeing your PCP or neurologist and having a talk about these things. And then finally, for people who don't like taking extra tablets, there are non-pharmacological treatments like botulinum toxin, like nerve blocks, and then there are even non-invasive non-pharmacological treatments like transcranial stimulation and then stimulation of the nerves via these devices that you can wear. So there are lots of options out there. So thank you for your attention. Thanks for tuning in. If you have any questions, I'm happy to answer any or all of them. Please just contact the organizer of these events and they'll be able to put you in touch with me. So thank you and best of luck.